Everybody. Today I'll be talking about drug-resistant TB. This drug-resistant TB is a menace which is looming in the horizon, and it has been seen whenever you start a new treatment of TB, as much as 3 to 4% are drug-resistant, and if it is a retreatment case, then it goes up to 11%. Unfortunately, children are innocent bystander. They acquire the disease from an adult. And no wonder it has been said the incidence of drug-resistant TB in children actually reflects what is happening in adults. So before going to the subject proper, let us take a few quick look at a few definition. Resistance to any first-line drug excepting rifampicin is known as monoresistance. And polyresistance, as the name suggests, is resistance to two or more first-line drugs excepting both rifampicin and INH. And multi-drug resistance is resistance to two or more first-line drugs in which rifampicin and INH should be always there. And pre-extensive drug resistance means it's a multi-drug resistance along with resistance to either fluoroquinolones or second-line injectables. So either fluoroquinolones or second-line injectables. And extensive drug resistance is multi-drug resistance along with resistance to both fluoroquinolones and this second-line injectables. Of this very one important point, I'd like to state that the drug resistance survey conducted in India has shown that rifampicin resistance is always associated with INH resistance. Almost they go hand in hand together. RNTCP has taken a very important programmatic decision in India that all cases of rifampicin resistance should be taken as resistance not only to rifampicin but both to rifampicin and INH, or in other words, all cases of rifampicin resistance should be taken as multi-drug resistance. Again, I re-emphasize RNTCP has taken a very important programmatic decision in India that all cases of rifampicin resistance should be treated as multi-drug resistance, that is resistance to both rifampicin and INH. So before going to the drugs and other things, let us take a short look what is the basis of anti-TB therapy. We know that tuberculous bacilli is an facultative anaerobe with a growth doubling time of 20 hours. They are present in different levels of metabolic activity and different levels of susceptibility to anti-TB drugs. So it has been seen in the walls of the cavity where the oxygen tension is high and the pH is neutral. In the walls of the cavity where the oxygen tension is high and pH is neutral, the organisms are actively multiplying. And here the most important drug is INH, rifampicin, streptomycin, and ethambutol. They are rapid multipliers. Whereas inside the macrophages, where the pH is acidic, the drugs are multiplying very slowly. And only one drug is active against that, that is pyrazinamide. And they are known as persisters. Another group of bacilli, which are inside the caseous tissue, where the pH is still neutral, but oxygenation is slightly less, they multiply only in spurts, multiply after some time in spurts, and they are known as sparters. And for the sparters, the drugs which can be used is rifampicin and INH. And there's a fourth group of tubercle bacilli which are dormant, and no first-line drugs are going to act against them. And there's a constant shift between these different metabolic uh, classes of bacilli. So we have rapid multipliers for which INH and rifampicin. We have persisters for which pyrazinamide is used, and we have sparters for which rifampicin and INH is used together, and dormant drugs for which dormant bacilli for which no drugs occurs. One of the reasons, unlike other infection, the reason why we combine so many drugs and given for such a long time therapy, because of these sparters and persisters. If you don't kill these sparters and persisters, it is going to relapse. So that's the reason why we give so many drugs and for such a long period in case of tuberculosis infection as compared to the other infection. Now, another important point you should know that in children, the tuberculosis infection is usually paucibacillary. A simple pulmonary primary complex consists of 10 to the power 4 to 10 to the power 5 bacilli, whereas a progressive primary disease or a cavity roughly 1 inch diameter, they contain bacilli in the tune of 10 to the power 9. The mechanism of resistance to anti-TB drug is by spontaneous mutation occurring in the tubercle bacilli. They don't share resistance with each other. And there is you can predict the chances of this spontaneous resistance. It has been seen that one bacilli out of 10 to the power 6 will show spontaneous resistance to INH, whereas in case of rifampicin, 1 out of 10 to the power 8 will show resistance. Now, supposing, let us take an example that a cavity which contains 10 to the power 9 bacilli, if you treat this cavity only with say INH, then what will happen? In this 10 to the power 9 bacilli, 10 to the power 6 will be sensitive to reform INH, whereas 1000, that is 10 to the power 3, will be resistant to INH. So if you give INH, initially what will happen? The sensitive organisms will be killed, but this 1000 bacilli will gradually uh, uh, multiply, and they will give rise to an INH resistant tuberculosis which will develop sometime after. Supposing now if this INH resistant bacilli you are treating with rifampicin only, then again what will happen? Out of this 10 to the power 9 INH resistant bacilli, 10 to the power 8 will be killed by rifampicin, but 10 will be resistant to rifampicin. So in time, they will also get resistance. So if you give a single drug to any failing regime, you serially select resistance. This is known as domino effect. But had it been so, if you have given combination of INH and rifampicin, then those bacilli which are resistant to INH will be killed by rifampicin, and those bacilli which are resistant to rifampicin will be killed by INH. The chances of a bacilli being resistant to both INH and rifampicin is in the tune of 10 to the power 14, which is very, very high, which usually doesn't occur. So that is one of another reason why we combine drugs in case of tuberculosis to prevent resistance. So there are four groups of drugs we give. Number one, drugs which rapidly clears or rapidly kills the rapidly multiplying organism, drugs which are for persisters, drugs which are for sparters, and combination of drugs which are for prevention of resistance. So that's the reason why we give so many drugs for so many. But again, I tell you, fortunately, childhood tuberculosis is possibly disease. The number of bacilli is less, so the chances of harboring resistant bacilli is very less, and usually children acquire the disease from an adult. So with this, we come to the subject proper. Before embarking a treatment for drug resistant TB where you have to use second line drugs, you have to think of certain things. The treatment for drug resistant TB is often very long, at times as long as 2 years. Think of the trauma, the anxiety both the child and the parents will have if you have to give injections every day for 2 long years. And usually we give injections 6 days a week with 1 day holiday. Think the difficulty. Number two, the drugs which we use in second line are very much toxic. Often it so happens the child develops toxicity that you have to stop the drug or you have to design another regime. So it is more toxic, more painful. And the supply of drugs in the private market is most erratic. So you cannot ensure a continuous supply of drug for such a long period. And finally, to ice the cake, the second line drugs are very costly, almost 100 times more as compared to the first line drugs. So before embarking on such an hazardous journey of second line treatment of drug resistant TB, you have to think twice that you are diagnosing the disease properly. And you have to ensure the supply of drugs must be uninterrupted, because if you stop the medicines at a middle of the therapy, you are going to land up in deep trouble. So this is WHO guideline in 2016. They have given a list of which are the drugs which you are going to treat. You don't have to remember anything. Just look at the list. It consists of first line drugs, fluoroquinolones, and injectables, second line injectables. And you see the fluoroquinolones, levofloxacin, moxifloxacin, another gatifloxacin, and you have second line drugs, amikacin, capreomycin, kanamycin, and third line you have something like ethionomide, prothionomide, and the fourth, these are of uncertain efficacy. Supposing if you cannot get a combination of 3 or 4 drugs, then you have to add 1 or 2. And in these drugs with uncertain efficacy like bedaquiline or delamenide is there. If you look very carefully at these drugs, all these drugs, none are for anti-TB action. They are discovered for something else. And incidentally, anti-TB action has been found and they have used. 2019, now you see what has happened. The latest drug which should be used according to who? The things which are lying down, drugs of unproven efficacy, bedaquiline, has climbed up to the top. So much so, now it has been told that you have to use this drug, all these 3 in group A. The drugs which are top in the list, amikacin, now it has fallen down to low. So why this change has occurred? The drugs which are thought to be very effective has fallen down. It was Ahmed who studied more than 12,000 patients in different countries using these second line drugs, and what was the result of their treatment. He found out a very interesting thing. He found out that those patients who were treated with second line injectables like kanamycin, capreomycin, the threshold of success, this is the average threshold of success, it's much below. The chances of death, if you use kanamycin, capreomycin, is above the threshold. But if you use other drugs such as bedaquiline, moxifloxacin, it is chances of death is much low. Chances of success if you use moxifloxacin, bedaquiline is much higher. So that's the reason why these drugs, second line injectables, has fallen down from the ladder. Friends, 55 decades has passed since the discovery of rifampicin. We didn't discover any anti-TB drugs. It took 5 decades to get a very important drug which is known as bedaquiline. Bedaquiline acts against the ATP of tuberculous bacilli. And what is more interesting, that it can kill both replicating and non-replicating bacilli. It's an excellent drug. The only blotch in the otherwise clean slate is that it causes prolongation of the QT intervals. Fortunately, children don't have that much of cardiac arrhythmias. So if you use bedaquiline, it is always better. You should get an ECG done. And the child has any problem of rhythm disturbance, you cannot use this drug. Another important drug, just a minute, one of the Beta-quinolone has approval of to be used above 16 years, but very soon it is going to be approved to use from 6 years onwards. The next important drug which we have discovered very recently is the delaminide. It is also a bactericidal drug which prevents formation of mycolic acid, which is a very important constituent of the tuberculous cell wall, and it has recommendation from 6 to 17 years, but within a few years it will be recommended for 3 to 6 years. So with this background knowledge, I come to my first case. This is 12 years old Raju, who is a son of a truck driver, has come with cough fever for last 2 weeks. The fever was not documented, but the mother told he has unremitting cough. His father is a smoker and has coughed for a long time. Father has visited RNTCP, has taken TB medicines for 3 months, after which he was slightly better and he has stopped taking medicine. Subsequently, the father was sick and diagnosed HIV positive and has taken multiple courses of anti-TB medicines, but irregularly several times. Raju was investigated and found to be smear positive TB, and he was put on 2 HRZD and 4 HRE, the standard regime. And after 2 months of 2 HRZD and 2 months of HRZD of therapy, Raju didn't show any clinical improvement. His sputum was positive and his X-ray was such. So my question is, what went wrong? The thing which went wrong is Raju is a case of presumptive drug-resistant TB. Smear examination is never an investigation of choice for a drug-resistant TB because smear cannot distinguish between drug-sensitive and drug-resistant bacilli. So who are the presumptive drug-resistant TB? Previously, we used to use the term suspected drug-resistant TB, but as the word suspect carries a stigmata, so we don't use the word suspect. From now onwards, you will call them presumptive drug-resistant TB. Any children who is in direct contact, that means a household or close contact of a drug-resistant TB is presumptive drug-resistant TB. Any children in whose family has taken multiple courses of anti-TB drugs, has a failed TB treatment, or death in the family due to TB should be taken as a presumptive drug-resistant TB, and any children who is living with HIV should be taken as a presumptive drug-resistant TB. Beside this, a child who is non-responder to first-line drug. What do you mean by non-responder? After giving 8 weeks of first-line therapy, if the child doesn't show clinical or microbiological response without any apparent reason, then you take it as a non-responders. If the child is a relapse, a child who has completed a full course of anti-TB drugs and declared cure has now again come back with a microbiologically positive or clinically positive TB. That we call it a relapse. Defaulter, any child who has taken more than 4 weeks of anti-TB therapy and then lost to follow-up and has again come back with TB, or any child who has been previously treated with the second-line drug. So these are the all cases of presumptive drug-resistant TB. And for them, you should never ever do a smear examination. What you need is an upfront molecular method you have to do. There are certain methods which has been approved by World Health Organization. We call them WRDT, who approved rapid diagnostic tests. And of this, CBNAT is the most important. So upfront molecular method should be done in all cases of presumptive drug-resistant TB. So before, once you have a case of presumptive drug-resistant TB, the most important thing you are going to do is take a very careful history, especially the history of usage of anti-TB drugs in the family. What is the social status of the family? What is the cough etiquette of the family? Does the family member spit at the corner of the room? How much crowding is there? So these are the very important histories you should take whenever you come across a drug resistant TB. History will provide you the clue that the chances of how much fair chances that the child might suffer from drug resistant TB. Next, you have to do a very thorough clinical examination and investigation. As I've told you, the second line drugs which are going to use is very toxic. So you have to have a baseline information about all the system, starting from central nervous system, eyes, even the psychiatric history of the child or mental history of the child is also important, because all these second line drugs can almost involve every system. Another very important thing you have to do, all cases of TB, be it drug sensitive or drug resistant, HIV testing is a must. I'll come to with this in little bit detail. And after that, you need a microbiological diagnosis and a drug susceptibility testing before embarking on treatment. So coming to HIV, HIV and TB is made for each other. They go hand in hand, they potentiate each other. Both HIV and TB, their presentation is similar. And if you miss any of them, no matter what therapy you give, the child is not going to improve. So they have overlapping symptoms, not only overlapping symptoms, the radiology is also same. The various means of diagnosing of TB, if the child suffers from HIV, becomes less sensitive. Tuberculosis sensitivity test decreases. That's the reason why we take 5 millimeter in duration as positive in HIV positive patient. If the child is suffering, a child with TB is suffering from HIV, then the pattern of the TB disease also change. They will have more of extrapulmonary TB, and the chances of isolating bacilli in the sputum becomes less. Another very important point, they potentiate each other. Supposing a child who is only tuberculosis infected, that means his MANTU test is positive but does not show any evidence of disease, the chances of developing disease if the child is HIV negative is only 10%. But if the child is HIV positive, then chances of disease is as high as 60%. One should remember that HIV epidemic paves the path for TB epidemic and vice versa. And when these two epidemics intersect each other, they spawns a third epidemic, that is multi-drug resistant TB. And now we are seeing both HIV and TB epidemics going hand in hand. So the chances of a third epidemic, that of multi-drug resistant TB, is very high. So after taking a proper history, after proper clinical examination of the child, you do an HIV testing. Now we need a microbiological diagnosis to prove that really we are dealing with a case of drug resistant TB. There are two types of laboratory methods we did. One is genotypic method, another is phenotypic method. In genotypic method, you detect certain nucleotides sequence in the genetic material of the bacilli to prove the diagnosis and also to prove that this bacilli is resistant to a particular drug. Again, I repeat, genotypic methods, we detect those nucleotide sequence which will prove, yes, tubercle bacilli is there, and this tubercle bacilli is sensitive or resistant to certain drugs. And in phenotypic methods, what you do, you actually grow the organism. So coming to the genotypic method, the most important method and the most revolutionary method which has come in the recent years is the CBNAT, where you get the test result within 2 hours. And along with that, there is line flow assays, where it will take some more time within 72 hours. And there is a third which has come, which is known as TB LAMP. But unfortunately, I have no much information on TB lamp. It is mostly done in adults, usually not done in children. In phenotypic method, what you do, you grow the organisms. Unlike the yesteryears, where you used to grow tubercle organism in solid culture, now this has been obsolete. Now what we do, we grow the organism in liquid culture. We call it MIGIT, Mycobacterium Growth Indicator Tubes. It takes 2 weeks or 14 days to grow the tubercle bacilli in liquid culture, and this culture isolate you can take from this liquid culture and then subject to LPA to have a sensitivity testing. Or what you can do, this culture isolate can be grown in drug free and drug containing medium to tell what is the sensitivity pattern of drugs. We shall come a little bit in details. So the most important test which we can do, microbiological test, is CBNAT. CBNAT can be done in both smear positive and smear negative samples. Smear positive and smear negative samples. You can do it for both pulmonary and extrapulmonary TB. CBNAT gives two very important information: whether the child is suffering from TB, and if the child is suffering from TB, that tuberculosis is rifampicin resistant or rifampicin sensitive. So the importance is that it can be done in both smear positive and smear negative sample. CBNAT can pick up samples containing as low as 130 bacilli per microliter. CBNAT can pick up. There is a new test is coming, which is known as RIF Ultra, rifampicin Ultra, which is one state ahead of CBNAT, where it has the sensitivity to pick up bacilli as low as 10 to 15 per microliter of sample. So this will be very soon introduced in our country. Unlike CBNAT, line probe assay can be done only in smear positive sample. Line probe assay can be done only in smear positive samples, so they are less sensitive than CBNAT. And the line probe assay will also detect TB, and they can also tell whether the bacilli which we have detected is resistant to first line drug or second line drug. When the line probe assay is done in smear positive sample, we call it direct line probe assay. But if the sample is smear negative, then what you have to do, you grow the organism in liquid culture, that is midget culture. After 2 weeks, if the organisms are present, it will grow in the liquid culture. Take that culture, isolate, and then do an LPA, when we call it indirect LPA. And LPA can also give result whether the drug which you have isolated is resistant to first line drug or it's resistant to second line drug. And the third is you can do a liquid culture, which can be done in both smear positive, smear negative, pulmonary, extrapulmonary TB. But only drawback of this liquid culture, it takes a long time. It takes 2 weeks to grow the organism, and it will take another 4 weeks to tell whether the sensitivity pattern of the organism, whether it is sensitive to first line drugs, second line drugs. And with liquid culture, you can do, you can show the sensitivity to almost all the anti-TB drugs. So how these tests go like this. So if you see the hierarchy of the test, the first choice is obviously CBNAT. And if CBNAT is not available, then the second choice will be LPA. And supposing if the CBNAT is not available, the sample is smear negative, that means does not contain less amount of bacilli, then what you have to do? You have to do a liquid culture, take the culture isolate and subject to LPA. So it is the second choice. And the third choice is liquid culture and liquid drug sensitivity testing. This is the third choice. It takes a very long time. So what I was telling, this is CBNAT. It is as easy as ABC. You just fill it, shut it, and forget it. If you see, CBNAT is a uh, integrated. That means what, you you don't have to process the sample. You put the sample inside the container. So the chances of contamination is very less in CBNAT. Number two. Number three is a real time. What do you mean by real time? At the same time, you amplify your nucleotides which are of interest, and at the same time you send a probe to detect. So amplification and detection goes side by side. So it is a real time. And thirdly, another very important is the nested. Nested means you are sending two probes, one probe to detect tubercle bacilli, another probe to tell it whether it is rifampicin resistant or sensitive. So it is very easy. It is just like fill it, shut it, and forget it. So again, I want to re-emphasize microbiological confirmation is a must when you are trying to treat a case of drug-resistant TB. Every effort should be done to get a result. If sputum is not available, go for induced sputum. If it is not there, go for gastric lavage, bronchoalveolar lavage, even go for lung tap. For extrapulmonary tuberculosis, aspiration, excision biopsy, CSF, even tissue biopsy can be done. Because diagnosis of drug-resistant TB without a microbiological confirmation must be again and again reviewed. Be it necessary, take an expert opinion, because you are going to subject the child to a long continued very toxic therapy and also a costly therapy. So you should review your diagnosis thoroughly. And in cases of high suspicion of drug resistant TB, but unfortunately you are not able to get a microbiological confirmation, you can diagnose clinically diagnosed multi-drug resistant TB. Again, I reiterate that give it a good thought before clinically diagnosing drug resistant TB. So with this, another definition has been there. They are known as probable drug resistant TB. Probable drug resistant TB are those TB who have signs and symptoms of TB and high chances of presumptive drug resistant TB, but you cannot diagnose them microbiologically. Those cases we call probable drug resistant TB. So diagnosis of drug-resistant TB in the absence of microbiological diagnosis must be thoroughly reviewed, as it is often untenable. And because you are going to embark on a treatment that has toxic effect, poor availability, and the cost of treatment is very high. So clinically diagnosed drug-resistant TB, before doing that, you have to think once, twice, thrice. You have to take an expert opinion and always try to have a microbiological diagnosis. With this, I come to my second case. A 10-year-old male child, 20 kg weight, has chronic cough for 3 months with exertional dyspnea. He has low-grade fever for same duration. His father died recently of recurrent cough with occasional hemoptysis, but usually took Ayurvedic or homeo medicines. On examination, the child had bilateral lower lobe scrapes. Oxygen saturation in room air was 88%. His counts were total counts 7,000 with neutrophil 78, lymphocyte 20. Tuberculin sensitivity testing was negative. Sputum was done for 2 days, but negative for AFB. And the CBNAT also done from pulmonary specimen, and it was also negative. And this is the X-ray. The child was started on anti-TB therapy with 2 HRZD, 4 HRE on the basis of symptoms, X-ray, and contact history with the father. So it was a clinical radiological diagnosis. But after giving 2 months of therapy, there was no improvement. His oxygen saturation further deteriorated. Now he has become dyspneic as death, fever persisted, and there is further weight loss. So what is your thought? We have seen so many cases of pulmonary TB. How many of the pulmonary TB, at least in the beginning, has come with an oxygen saturation such low? We hardly come across this. Blood glycomenon test was done and it was negative. So aspergillosis was ruled out. As there was persistent hypoxia, we did an ABG, which showed PO2 of 60%, very low. And the sputum eosinophil count was 30%. So a modified AFB stain was done and it was found to be PCP cyst positive. So it was a case of pneumocystis carini. So here lies the importance. Before going for a diagnosis of drug resistant or TB, you should always go for a microbiological diagnosis because there are certain conditions which mimic TB. Heading the list which mimics TB is HIV. Non-tuberculous mycobacteria is another infection which mimics tuberculosis like anything. So also is pulmonary aspergillosis, cystic fibrosis, sarcoidosis, to name a few. This non-tuberculous NTB, non-tuberculous, usually is seen in case of immunocompromised elderly person, but in case of children, sometimes you can have this NTM, non-tuberculous mycobacterial, even in apparently healthy children. They usually come with lymphadenopathy, and their lymphadenopathy is usually non-tender. They don't have any constitutional symptoms. There's no family history of contact. No matter how many courses of antibiotic you give, it won't improve. And what will happen? This will soften and this will start discharging. It has a very poor cosmetic value. And if you do an X-ray test, it will be negative. A TST is non-reactive. Smear might be positive, but CB-nat will be negative. This is a very important clue. Smear positive, but CB-nat negative. Then you think of non-tuberculous mycobacteria. Similarly, sarcoidosis is another cases where you have multiple lymphadenopathy, including generalized lymphadenopathy with non-specific markers with raised inflammatory hypercalcemia. And the diagnosis is usually by biopsy, where you get a non-caseating granuloma, unlike tuberculosis, where you have a caseating granuloma. So before, if you ever make a clinically diagnosed drug-resistant TB, think of these conditions. They mimic TB like anything. So now we have taken our case, a proper history. We have examined HIV, we have examined, done a microbiological test, and now we have found that that molecular test should be done for every suspect. And now we have found that rifampicin status. Why the importance of rifampicin sensitivity or negativity? Because on the basis of rifampicin sensitivity and negativity, we decide very two important things. Before the drug sensitivity testing, other results are available. On the basis of rifampicin sensitivity, we give presumptive therapy. And on the basis of rifampicin sensitivity, also we decide what further drug sensitivity testing we are going to do. If the patient is rifampicin sensitive, a patient who is suspect, who is presumptive drug resistant TB, is rifampicin sensitive, then we are going to check resistance pattern only to first line drugs. Whereas if the patient is rifampicin resistance, then we are going to check drug sensitivity pattern both to first line and second line drugs. So before now, we know our case is tuberculosis positive and he has rifampicin uh, resistant drug resistant TB. So before going to the treatment regime proper, one important thing you should remember, you are not supposed, as a general pediatrician, you are not supposed to treat drug resistant TB. You should always consult the persons who are expert in that. RNTCP has excellent services to deal with drug resistant TB. So always consult one of their expert. If you consult one of their expert, not only the battery of tests, which are usually not available in the private market, will be available. Also, you will ensure that the patient receives an uninterrupted drug supply. And also there are persons which will visit the home where the child stays to understand the socio-dynamics and also Government of India is going to give certain benefits, monetary benefits to the family so that the child can be given a proper nutritious diet. If so happens that the drug sensitivity pattern in the child cannot be tested because of the lack of samples or paucity nature of the samples, then susceptibility of the source sample from where the child has acquired the infection, that will guide what sort of therapy you are going to give. Usually you use 4 to 6 bactericidal drugs, and we can modify the empiric therapy, which we start right once as we diagnose it's a rifampicin resistant on the basis of drug susceptibility pattern. And I have told you, never add a single drug. If you add a single drug, this will have a domino effect or it will serially select resistance. So you should never do that. So before treating, it's a pre-treatment evaluation is very important. As I've told you, these drugs are very toxic. Almost all the systems of the body, central nervous system, eye, pulmonary system, the gastrointestinal system, hepatobiliary system, urinary tract, everything should be investigated properly. A very detailed history should be taken, weight, height recorded, routine blood test along with liver function test, kidney function test, routine urine, thyroid function test, X-ray, ECG, serum electrolytes, eye checkup, EEG, everything should be done before going for this therapy. So you do these things, and there are usually two types of treatment. One is standardized treatment and is individualized treatment. Individualized treatment is given solely on the basis of the drug sensitivity pattern of the person, but we don't use individual treatment in our country. We use standardized treatment because standardized treatment has been approved by RNTCP and it can be had from the RNTCP center at the free of cost. So always we use standardized treatment on the basis of the drug surveillance which has been conducted extensively in our country. So now our it should not be a suspect, it should be drug resistant TB presumptive. CBNAT is done. If it is rifampicin sensitive, Rifam drug resist tuberculosis is positive, but rifampicin is sensitive. Then what you do, you put the child on first line drug, 2-HRZDA and HRE. Then you do a first line LPA. And if the LPA shows the INH is along with rifampicin sensitive, INH is sensitive, then you continue with the same treatment. But if the INH rifampicin sensitive but INH resistant, then you give a uniphasic regime. Uniphasic regime, we usually give intensive phase and continuation phase. Here the same drugs are continued for long 6 months. Again, I tell you, you need not bother about remembering these regimes. You are not supposed to remember this regime. There are persons who will take care of this. But now the problem starts if the child who is a presumptive drug resistant TB now has a rifampicin resistance. If it is a rifampicin resistance, there are 3 types of empiric therapy where you can give a short MDR treatment if the child is suffering from say only pulmonary or lymph node TB. But if it is an extensive TB, then we give a long therapy. But you need not, again I tell you, you need not remember these regimes, which is virtually impossible. But depending upon the condition of the child, we select this empiric regime, and thereafter we do both first line and second line sensitivity testing. On the basis of this, usually nowadays we use this regime where it is an, if you look at very carefully, this is an fully oral regime where you give delaminide or bidaquilone along with levofloxacillin. So this is a fully oral regime which can be given, or also there is a short course, both injectable and oral regime. But again, you need not worry about this, what different drugs you are going to give. You are not going to select what treatment you are going to give, but you are going to do one thing. You are going to monitor the child. Monitoring the child is your responsibility. You have seen the child right from birth. You have nurtured the child till today. So the parents will want monitoring of the therapy should be from you. So we do 3 types of monitoring. We do a clinical monitoring, radiological monitoring, and microbiological monitoring. Of this, for obvious reason, microbiological monitoring is the most important, but clinical monitoring is usually done every month, where every month we check We check the weight and height of the child. We see whether the child is growing properly, whether the symptoms with which he came has subsided. And another very important thing you are going to see, whether the child is developing any side effects. That's a very important. And of microbiological monitoring, we do two important things. We do a smear and culture examination. And again, for obvious reason, it is the culture examination which scores over smear examination. And we give more emphasis, more importance to culture examination. So if the regime is less than 1 year, then we do smear every month during the intensive phase. And then again, we do at the end of IP, that is intensive phase, and again at the end of treatment. But for regime culture, we do smear monthly in the intensive phase and culture at the end of IP and at the end of treatment, or if due to some reason there's extension of intensive phase. For regimes more than 1 year, you have to do monthly smear and culture for 3 months, and thereafter quarterly in case of continuous phase. So monthly first three, after 3 months in during the intensive phase, and quarterly in continuation phase. And if two culture reports are negative for short-term therapy, or three culture reports are negative in long-term therapy, of which the last culture has been done at the end of the therapy, and at least they should be 1 month apart. If negative, then we call it a cure. So with this, I come to my last case. A 12-year boy was diagnosed as a case of TB lymphadenitis on the basis of clinical finding and FNAC for TB, and CVNAT showed rifampicin sensitive. He was given 2 HRZD, 4 HRE, and has completed full treatment. After completion, still there are grape-sized swelling persisting. These glands were non-tender. There's no overlying skin change. The boy had no temperature with normal activity and appetite. The parents were worried about the non-resolving gland. Attending physician investigated again after completing 3 months of therapy. And he found his routine blood was normal, his X-ray test was normal, and to his utter surprise, he found the CBNAT, which he done from the FNAC of the gland, he found MTB detected and rifampicin sensitive. So he was at a dilemma. He was thinking that whether I am dealing a case of drug-resistant TB as the CBNAT is positive. Is he right or wrong? He is totally wrong. CBNAT is never ever done for follow-up of TB cases. For follow-up of TB cases, you either do a smear or culture. CBNAT can detect those dead bacilli inside the glands. If the child does not shows increase in the size of the glands or no constitutional symptoms, most likely it is these glands are going to take a long time to resolve. So this is not a case of drug resistant TB. So CBNAT is never ever, CBNAT, LPA, these things are never ever an investigation for follow-up of TB. For follow-up of TB, again I reiterate, either you do a smear or culture, of which culture is the most important. It scores much higher above smear. So my last tail piece is confirmatory diagnosis of childhood drug-resistant TB is difficult, but every effort must be given to come at a microbiological diagnosis. No stone must be left unturned. You should never ever venture to treat a drug-resistant tuberculosis of your own. You should do it always in consultation with an expert. Involve the district tuberculosis officer. They are more than eager to help you and to bail you out. Counsel the parents properly. This is a long journey. At times, the child might suffer from toxicity and other, but this is the last fight, and you have to win this fight, and you have to win decisively. And another last very important thing, all TB cases, be it drug sensitive or drug resistant, must be notified to the RNTCP, and failure to do it may lead to prosecution. So this is what has happened. Number of private clinics, hospitals, they don't notify the TB, and even notices and FIR can be done against you. So with this, I thank you for your patient hearing.
Ritabrata, I had one suggestion.
Hmm.
Hello.
Yes, I can hear you.
That's one suggestion, that you are telling that you don't have to aware of this, all these thing, all these drugs and all this. You should send it to the special persons.
Ha ha.
Ah,
Right.
but
Ha.
thing is that
You have to
they were
diagnose.
also,
Ah.
but they were also a dilemma.
No,
For
they are
when they
not in a
detect,
dilemma. They have.
let me finish.
Ah, hold on.
When they are at a dilemma and regarding when they send it back to you to decide the dosage of drugs and all these things.
Like,
They will
dosage
give
of
you the
drugs, so
drugs,
you can do, but they will tell what
but
plan
they
of
will. I
therapy.
have one patient. I send it to them, but they again referred it back to me. They said it, adjust the dosage and all these things regimen we have given, but the dosage for pediatric age group you should
Doses are
monitor.
written, Mayadi. You can always do that. That is not the problem. You
Mahdi,
can.
It is
Mahdi,
their problem, but
what
they
I
don't. They were not very accustomed with the pediatric dosage. That's
No,
what I
yeah,
am telling. The
that you can
present
do.
generation should know the drugs and the dosage and all this thing.
Mahdi, I mean, let me tell you, I never calculate the dose myself. I involve my residents because calculating the dose of a TB drugs is time consuming. So what I do, I don't do it in my clinic. I ask them to my hospital. I ask my residents to calculate because there are bandings. Depending on that, you will have to calculate. I take the help of the juniors, and because of that, they are also not very confident in prescribing drugs to the pediatric patients. So that's number one. But I have got little bit uh, confusion about their experience because, as Ritabrata said, that AB positive, CB-NAT negative means it's an atypical mycobacteria.
Most
And
likely.
few days back, I had a patient where it was AAP negative, but CB-NAT AB positive but CB-NAT negative. So I was treating this child as an atypical mycobacteria, and everybody knows that there is no really fixed schedule or protocol for managing an atypical mycobacteria. There are two options. Either you give the drugs like rifampicin, ethambutol, or a fluoroquinolones, or you
Erythromites
take it
or
off, or
macrolides. Macrolides.
macrolides, yeah, macrolides, especially the
Plus minus
clarithromycin,
amikacin.
especially the clarithromycin,
Hmm.
and or you take it off. Now, this patient was given on the basis of that the drugs like rifampicin, ethambutol, and levofloxacin and clarithromycin didn't work very well, and sometimes it may not work. So I was planning to take it off. Then I took Ritabrata's opinion, and he said send them to the district tuberculosis officer. And what he said, that it's a totally wrong treatment given because he didn't understand the importance of AB positive and CBNAT negative. He thought that since it is AB positive, it has to be like tuberculosis, which is not. It's not typical tuberculosis. And second comment that I would like to mention, that Pneumocystis carinii name has been changed long to
Ah, PC.
Pneumocystis xerovesi.
Ah,
So in our presentation, we should not say Pneumocystis
this is correct.
carinii anymore.
Ah.
And
Key zero basic.
uh,
Pneumocystis zero basic, na?
Pneumocystis xerovesi.
Ah.
And about galacto, you said
Galactomannan test. Galactomannan.
galactomannan. Yeah, galactomannan. I was little confused about these pronunciations. It's a galactomannan test, but
Ah.
not really very solid test to
Usually we do it.
no, we do it, but it's not a very solid test to diagnose aspergillosis.
Aspergillosis.
Yeah, but we still depend on precipitin test. We still depend on IgE level. These are there is no direct test for aspergillosis.
Yes.
Sir, I
So,
have I have
Mayadi, what I tell you, the drug dosage are very clearly written now. The whole dosage has been revised. We used to give INH at the dose of 5 milligram per kg. Now you cannot give less than 10 milligram, and it's always better to go on the higher side. Regarding what Apurva has says, unfortunately, non-mycobacterium tuberculosis, their treatment response is very poor. And most of the cases, all you have to do, because if you don't treat and if they're not going to respond, they are going to burst. And it is a very, very shameful sight. Also, it's a cosmetically very bad looking. So ultimately, most of these glands have to be operated and taken up. I think Provas has some question. Provas,
Yeah.
please.
Sir, it is very difficult to diagnose drug-resistant tuberculosis in the pediatric population
I
because,
know that.
as you know, that most of the pediatric population tuberculosis is postbacillary tuberculosis.
Hmm.
Very rarely we
Summer
used to
sir,
get some
watching
AFP
disturb
positive tuberculosis cases. In most of the cases in pediatric population, either we give and radiological evaluations, and few of the cases with the help of positive gene expert. The only, I think, till my 12 years of pediatric experience, I have given AB positive as an anti-tubercular drug almost 5 or 6 cases. Most of the cases are clinical diagnosis with the help of radiological evaluation, and after the advent of CBNet, it is very much helpful. So suppose we are getting a case which is typical of tuberculosis, any site, it may be a bone or
Hmm.
a
Right.
CNS or pulmonary.
Hmm. Hmm.
It is strongly clinically suspect tuberculosis, radiologically suspect tuberculosis, and CBNet positive. After giving antitubercular treatment, we have tried to isolate the AFB positivity, and it was not positive, and culture was not done as a routine procedure. So after giving ATD treatment, so the child is not responding. So how to suspect this case as a drug-resistant tuberculosis? Because we did not have any AFB documentation for this case. There will be other causes, like most of the tubercular meningitis. You maybe know that, maybe aware, for the last couple of months we got almost 10 or 12 cases of tubercular meningitis. It is very difficult to get similar positivity in the CSF. So all in the cell counts and my MRI pictures, we are giving ATD, and most of the patients are not properly responding.
No,
So how to detect that whether we are dealing with a drug-resistant
two
tuberculosis or
two
not?
important changes has been coming very recently. One is Reef Ultra. Reef Ultra will have a detection capacity as low as 10 to 13 bacilli per microliter. So it will be able to pick up those samples which we usually get negative, say pleural fluid, CSF
Yes,
fluid.
it is already in the market, Ritabrata. It is already in the market.
Reef Ultra, no, Reef Ultra, I don't know
Yeah,
whether
it is.
these are authorized or not, but it is not authorized by Government of India, what we are getting. As number two, another important TST, if you see the recent guidelines or RNTCP, TST test has been withdrawn because this Mantu solution, what we get in the market, these are all not standardized. Another very important thing is coming is CTB, Copenhagen TB. That with that we will do TST next generation. These are very highly sensitive, and there the positive rate has been brought down to 5 millimeter. So with these two newer, I think we can diagnose more. But what I wanted to tell at the end of the day, that we do give clinically diagnosed tuberculosis, we do, but never give therapy to clinically diagnosed multi-drug resistant TB. Don't do that. You will be in trouble.
Oh
There is a
yes, I mean one of the problems we face is that once in the periphery, especially once they find AB positive, they stop investigating and starts anti-tubercular drugs. Now remember that the inc- incidence of drug-resistant tuberculosis is in children is only 2.2%. And what has happened is this child from Medinapur was positive AFB and was given anti-tubercular drugs for 6 months. So patient didn't improve and came to us, and what we found that this is a drug-resistant tuberculosis. So AFB positive পেলেই আর
We
সিবিন্যাট
should
করব
not do
না,
that.
that temptation has to be stopped
Stop. You have to
because
always see
AFB,
reformation sensitivity. Yes,
yes,
and
yes,
and
and also not only two reasons. One is it might be a drug resistant or it might be an atypical mycobacteria
yes.
also. So for these two reasons, you should
Another
always go
important
for
thing
the
I
test.
want to suggest, that you have to make the habit of sending MGIT, microbacterium growth into a
Yeah.
culture, because culture is much more sensitive. It can pick up very few say 5 to 10 bacilli even in the sample. So this we underuse this. I think we should use this. And this MGIT is not that much costly also. We do so many costly
Yes.
tests, we can do that also.
Yes.
Another thing is
And
that
uh, ball.
about the treatment of the newly diagnosed tuberculosis, whenever you are referring this case to RNTCP centers, so
Hmm.
sometimes they are giving the dose of normal firstly diagnosed newly diagnosed tuberculosis.
Hmm.
Sometimes they are giving HRJD, sometimes they are giving HRZ with streptomycin injections. Sometimes we write it down that do not give streptomycin injection. We want ethambutol. Then they getting it back and giving us ethambutol. A few
I think
occasions I
that
have
is,
seen that in the continuation phase, they are not giving ethambutol. They are stick to the old protocol of 4HR. You can
no,
remember the 8 months ago, I called you at the evening. They said why they are giving only HR. You should be giving HRE. So they are stick.
yes, no, I think that is something which should not have been done. I don't know
Another
why
thing is
they
that
are.
Prabhash, at this point, I was going through some international articles on tuberculosis, and nowadays no one mentions about streptomycin. They give amikacin, and because amikacin is more easily available, I would prefer amikacin rather than streptomycin. I don't know about our country, but
Hmm.
in the West, they don't
Because
give.
we don't have facility to monitor hearing and other things. Amikacin is
Oh
a
yeah, no,
fairly toxic drug. We don't.
Ritabrata, streptomycin is
Yes,
also
so
an
streptomycin
aminoglycoside,
down uthei
and
gache.
it
That
will
was
cause the
already
same
withdrawn.
problem. It will cause the same problem as that
Huh.
of amikacin.
So streptomycin
There
is
will
no
be
longer
no
used.
difference.
No,
There will
no
be no
difference.
difference.
Streptomycin. That's the reason streptomycin has almost withdrawn. We don't use
No. I
streptomycin.
mean, but if you are trying to give an aminoglycoside for tuberculosis, they have mentioned about amikacin.
Yes, but here
They
you
have,
are giving amikacin for as long as nearly 6 months. If you are treating a drug-resistant TB, 6 months ki 1 year.
no, see, once the especially for tubercular meningitis, this is being used. Otherwise,
I'm
extra
talking about drug-resistant TB. So
yeah,
here you have to give for a long time. So regular monitoring of hearing, renal, this is very, very important. If you use this
no, I'm not
drugs for
talking about drug resistant tuberculosis
Acha.
because that's not my domain. I will
Drug-sensitive
not
tuberculosis,
enter.
nowadays we don't give streptomycin anymore.
Yeah, but sometimes I have seen in All India Institute they give 5 drugs in tuberculous meningitis,
So as
including
long as
streptomycin.
IV channel is there, they will give another drug. The
Yeah,
principle is very simple. More amount of drugs that you give, more you are going to kill these persisters, the sparters, and the resistance preventing. So that's the reason. Because resistant preventing, there are two sets of drug. One is INH rifampicin, another is streptomycin ethambutal.
আরেকটা
so
question.
if a tuberculous meningitis someone um, uh, close to me, I would rather add a 5 drug amikacin for
You can give that for
yeah,
as long as IV
and
channel is
lastly,
there, but thereafter you have to withdraw it. You cannot give day in day out injectable IM.
আরেকটা
no,
হচ্ছে স্যার
I know.
স্যার 5 ড্রাগস বললেন, স্যার অনেক সময় 6 ড্রাগসও অ্যাড করেন, লিভোফ্লক্সাসিন একটা অ্যাড করে দেন। তো সেটা দিলে কেন দেব, জাস্টিফিকেশন কি, আমি
না
কতদিন দেব?
লিভো
স্যার
আমি
এটা একটু
বলছি
স্যারকে জিজ্ঞেস করে না, ভয় পাই, আমি জিজ্ঞেস করলাম
না না
ডাইরেক্ট।
আমি তো ওকে বলি লিভো হোয়াট ইজ দ্য রোল অফ লিভোফ্লক্সাসিন। Supposing if you are giving a child who is otherwise everything is no problem is there, there's no question of adding a levofloxacin. Supposing a child who has developed toxicity, the most common toxicity in anti-TB drugs is jaundice, liver function, liver toxicity, because all the drugs you are using is hepatotoxic excepting streptomycin ethambutal. So supposing a child has developed jaundice who is suffering from life-threatening TB, then you cannot withdraw anti-TB drugs. Then what you do, you withdraw the current drugs and you start with streptomycin, ethambutol, and levofloxacin. But supposing the child has developed jaundice, but his tuberculosis is not life-threatening, say tuberculosis lymphadenitis, then what you do, you withdraw all drugs. Repeat SGPT. When it comes down, add one drug at a time, and like this you build up again. So there you are justified to stop. But in those life-threatening TB, you cannot stop anti-TB drug even for few days. There in those cases we use streptomycin, ethambutal, and levofloxacin.
Yeah. And my last question to Dr. Kundu, who inspired you to be a tuberculosis specialist? Because
I am not a
I have been
tuberculosis
working with
specialist.
you for the last 40 years or maybe
No, no.
37 years.
So,
So what is your
unfortunately, when the
inspiration?
first
What is your
article,
inspiration to become
what
a
I'll
tuberculosis
tell you the
specialist?
inspiration. When the first article came, the mechanism of action of anti-TB drugs, I don't read any journal, but unfortunately or unfortunately, I came across a journal where the first this article was, and I read it. I was very much impressed, and then I was supposed to give a talk. Then I started speaking on this. So thereafter, if people thought that I am an expert in TV, and that's the reason nowadays, by hook or crook, I have to read TV. They like this it came.
এটাকে একটা ইউটিউবে দিয়ে দে না, সব ভুলে যাবো নইলে,
পাঠিয়ে যাবে আবার কালকেই কিছু
কিছুই মনে থাকে না।
কালকে it will change, don't worry. So thank you everybody.
Or you give us